Ethical Perspectives on the News is produced by the Interreligious Council of Lynn County, which is solely responsible for its content. The views and opinions expressed on this program do not necessarily reflect those of the staff and management of KCRG TV9.
Good morning and welcome to this week's episode of Ethical Perspectives on the News. I'm Martha Rogers and I'm the moderator of the panel today, and I'm really glad that you've joined us this morning. On November 1st, just about a month ago, Brittany Maynard, who had advocated for the right to death with dignity, died. And she died by choosing to take the medication designed to hasten her death and prescribed by a physician and in consultation with a physician. Maynard had lived in California and she was diagnosed with a really bad situation of brain cancer. And she chose to move to Portland, Oregon, because Oregon allows death with dignity, while California does not. This Oregon law isn't a new one. It went into effect in 1997, and the Death with Dignity Act gives patients who are 18 and over and are capable of making health care decisions and who are given no more than 6 months to live the option to take their own lives. Death with Dignity with Brittany's case raised a big conversation in the United States. They called it physician-assisted death, they called it suicide, they called it aid in dying. But what Oregon said was that this was legal. And it's legal in many states right now, at least 4. Oregon, Vermont, Washington, and in Montana, they had a court ruling that made it allowable. Last year, in 2013, in Oregon, 122 people were prescribed medication to hasten their death, but only 71 used these meds. Death with Dignity Acts raise a lot of questions, especially in a culture where we think we can live forever and that we can avoid talking about death or dealing with death. And I personally am really glad that we have an opportunity to put death in the forefront and to have this discussion this morning. New York, just last week, had a Democrat, Brad Holloman, put a law down for debate to raise this issue in New York. And as I sit here now in the beginning of December, New Jersey is debating it. It passed in the Senate and is being debated in the House, I believe. I might have that backwards, but they're discussing it this week. It's a good topic to discuss, and I have an excellent panel here to help me discuss it to engage you in this topic. I'd like to introduce the panel at this time. To my left, welcome, Janine.
Thank you.
This is Janine Idziak. She's the director of the Bioethics Center at Loras College and professor there. Welcome. I'm so glad you're here today. And next to Janine is Dr. Rebecca Benson. Rebecca, you're the medical director of the Pain and Palliative Care Center and do some ethics consult work with the University of Iowa Children's Hospital.
Yes, that's correct.
We're glad you're here too, Becky.
Thank you.
And rounding out our panel is Gary Sicard of the Libertarian Party, and welcome to both of you. I'm glad all 3 of you can be part of this discussion. It's a legal issue, and it's a medical issue, but it's also an ethical, moral, personal issue too. And as a physician, Becky, could you just help us understand more what death with dignity means when we hear that in the news?
Right. So the concept is that people who find out that they have a terminal diagnosis and may see that the upcoming future for them would hold a lot of suffering, or maybe they're already undergoing a lot of suffering, either physical suffering from pain or other intractable physical symptoms, or perhaps they have a psychological type of suffering, decide that they would like to have more control over the process of dying. Oftentimes these patients are referred to palliative and hospice medicine, and we certainly feel that that's a very important part of the process, is to make sure that we're doing everything we can to relieve their suffering. But some patients still would like to have that way out if the suffering becomes unbearable and intolerable, and would like that degree of autonomy and control over their dying process. And so they request from their physicians some aid in dying, which is usually given as medication, often a prescription for barbiturates. And in Oregon and states like that, the request must be made at least twice, once in writing. There's a process that's undergone to make sure that they've understood what their options are in terms of palliative and hospice care to prevent their suffering. And then once that physician and the patient are sure that that's the right option for that patient, the prescription is provided. At that point, the patient can decide at what point they would like to administer those medications, and many never do. They keep it as a way out in case things get too difficult or they're suffering too much at the end, while others do choose a time and a place that seems right to them to end their suffering.
So there's a lot of personal choice, but is a very controlled procedure with the physicians and the 2 or 3 interviews and requests in writing and so on.
But a practical difficulty that has been raised is what kind of control is there once the patient has been given the medication?
Say more about that.
Well, for example, if 2 physicians have to certify that the patient is terminally ill, they're supposed to undergo psychological testing and the like. But after that's done, the patient is simply given the medication, and we don't know what happens to the condition of the patient after that, whether there are any coercive pressures exerted on the patient or not.
By family or organizations or communities they belong to?
Exactly. So that's seen as a lacuna in the protective process.
So as I understand it, you're saying the patient is given the prescriptions, they can fill up the prescriptions, and then it's up to them just to take the medicine home and
decide if and when they choose to take it.
right, hopefully with family or with support if they're in a church or a faith community, or.
Right.
But you're saying there could be outside and undue pressures involved.
That's not precluded. That's a practical problem with this.
And it's not controllable.
Provision is not made for that.
Okay.
What type of provision in the law would make that acceptable?
Well, you're talking to someone who's against assisted suicide.
I understand.
Again, I think that there are some practical reasons to be concerned about this. For example, the laws typically cite 6 months as the point at which the patient is considered to be dying within 6 months. Well, there are some practical problems about that. It's an educated guess at best. For instance, some people go into hospice, and because of the good care they receive through hospice, they're essentially discharged from hospice, living much, much longer and a better quality of life than is expected. Furthermore, legally, what is sacrosanct about 6 months? Why not 12 months? Why not 30 months or the like? Again, picking that 6 months seems rather arbitrary. And I, again, see that as a practical problem with the assisted suicide legislation.
So let me just expand that a little farther. Then would it be illegal to do suicide at all, even if you weren't terminally ill? Let's say someone wants to kill themselves tomorrow. I mean, they're not terminally ill. Should that be illegal?
Now, if you look at the 2 Supreme Court cases dealing with physician-assisted suicide in 1997, the U.S. Supreme Court did not affirm that there is a constitutionally guaranteed right to assisted suicide. They didn't forbid it. They left it to the states to experiment with it. But on the other hand, they did not say we have a right to physician-assisted suicide. Also, there's a legal adage, hard cases make bad law. Hard cases make bad law. So again, in looking at cases where people are enduring extreme suffering, should that be the paradigm for what our laws as a whole say?
Maybe this is a good time to step back for a minute. You're using some terms that are so freely misunderstood. There's terminal sedation, there's assisted suicide, there's physician-assisted suicide, there's end of life, and I'm not even clear on what exactly it is other than that a prescription has been given and somebody has the control to end their life.
As a bioethicist, let me address those distinctions. If someone other than the patient initiates the action which causes death, that's considered a case of euthanasia. And euthanasia can be either voluntary or involuntary. If the patient requests that someone else initiate something that causes their death. That's voluntary euthanasia. If the patient does not make that request and it is still done, that is considered involuntary euthanasia. The difference between euthanasia and physician-assisted suicide is in terms of who takes the steps that immediately causes death. When you're talking about what you call the death with dignity laws in Oregon or Washington, the physician-assisted suicide laws, in these cases, the physician prescribes the medication which the patient takes home and takes on his or her own. So in being the one to ingest the medication, the patient is the one who is the immediate cause of his or her death. But whether you're dealing with euthanasia or assisted suicide, the intent in either case is to bring about the death of the patient. Now, there is also something called terminal sedation, or more often called today palliative sedation. The American Medical Association has studied this and considers it permissible when all other means have been exhausted to try to control the pain and symptoms of the patient. And in this case, with palliative sedation, with the permission of the patient is sedated to the point of unconsciousness on a continuing basis until death occurs naturally. So it is a natural disease process which is the immediate cause of death. And palliative sedation has been introduced as an alternative to resorting to assisted suicide.
Right. Another feature of palliative sedation, I'll say, is that it can be proportional. So while the intent may be to relieve the symptoms, in some cases that can be done without sedation all the way to unconsciousness, with the patient still able to have some level of interaction. So it's certainly a preferred step to consider in just about every practice of palliative care or hospice prior to considering a patient's request for physician-assisted death. And I would say that for some physicians, the reason that they would differentiate between physician-assisted suicide and physician-assisted death is because these patients are really in a process where they know their death is coming, and they oftentimes do not wish to die. That is not their intention. If it was not for their disease process, they're not suicidal in the psychiatric terminology, but they wish to have this level of control over their own death by being able to take a medication when things get unbearable. And so for that reason, some people prefer the term physician-assisted death rather than physician-assisted suicide.
Well, and the American Public Health Association, and I'm going to read right from my notes so I say it correctly, and I'm quoting from the American Public Health. They say the term suicide or assisted suicide is inappropriate when discussing the choice of mentally competent, terminally ill patients to seek medications to bring about a peaceful and dignified death. It says they wish public health would use accurate language, and the Medical Women's Association has also adopted as other national organizations. Well, let's get down to a question other than language that we hear all the time. Do we have a right to do this to ourselves?
If I may, the question comes down on the legal issue of, do we own our own bodies? Do we have the right to do to ourselves whichever we desire to do, so long as we're not harming someone else? In other words, if I'm terminally ill, or even if I'm not, do I not have the right to determine my own death? That's the question legally. Now, ethically, it becomes it comes a little more intertwined, because am I allowing someone to die that maybe isn't capable mentally to decide that? I.e. children. What if you have children that are terminally ill? Do they get to decide physician-assisted death?
Right,
No, they
the
don't.
laws, I believe, say they have to be 18 or
Correct.
older.
Correct.
But that's what I'm saying. But kids don't get to make that decision. And parents certainly can't do it, because then it's murder. So why do we allow adults to make the decision that are terminally ill 6 months, but not children to do so? Again, that comes back down to that mental state. So that's where the ethics of this, I think, get a little more harder to figure out.
Well, and then there's the faith community approach too. This program is sponsored by the interfaith community, and they may say, "Are we playing God?"
Right.
Well, beyond that, if I could relate some of the specifically religious arguments against aid in dying, physician aid in dying, if you want to use that terminology. There's a concept that life is a gift from God, and that we are stewards of our lives, not owners, so that it is not up to us to do whatever we want to with our lives. Secondly, within faith communities, suffering is not seen as something to be avoided at all costs. Now, surely we're committed to good pain control, but there may be a residue of suffering, either physically or psychologically. Again, within a religious faith context, that kind of suffering can be seen as character building for individuals, that it does have a point to it. Also, in terms of relationships with other people, it's been pointed out that people who decide to take their own lives can be missing out on some important, precious moments with family members in terms of what family members communicate to them by their caregiving when these people are at the very last moments of their lives.
Which would be different than being surrounded by family as you take your own life if you were terminally ill and doing the physician-assisted death with dignity. The witnessing that I've read about and heard is that the people really appreciate how a closure can come with the family by your side. As a doctor, do you see some of that, the difference between the caregiving for somebody that's terminally ill versus?
Well, we do have some data from Oregon about the patients who have gone through with physician-assisted death protocols. And what we find out about that population is that they tend to value autonomy very highly. So the main reason cited, oftentimes pain is involved, but not always, and never the sole factor. So I believe in about 24% of cases, concern about pain or pain that is inadequately treated is one of the factors.
You're talking physical pain.
Physical pain, correct. But autonomy, loss of dignity, loss of control over their bodily functions, loss of ability to enjoy their activities of daily living are some of the things that are really strongly endorsed by those who actually went through with the process. And so we do know that it's in some ways a unique population that perhaps values that above other things in their decision-making process. And I guess from a physician's point of view, it is a very contested issue among physicians. It's not supported by the AMA and many other medical groups at this point, but it's also, there's an undercurrent that we realize that we're changing the process by which people die by the support that we provide and the treatments for various illness. So if we're providing people with additional feedings that they would not be able to do on their own, treatment for infections, that's changing the dying process as well. So in a way, you know, we have to, I think, at least be cognizant of what we're doing to the dying process. People aren't able to go through the same process that they would have been without the kinds of technology and medication that we are now using.
Now, I'm against physician-assisted suicide, but I don't think just saying that ends the issue. The movement towards assisted aid in dying did not arise in a vacuum. It's a response to very problems people are having during the dying process. So I think if you're against physician-assisted suicide, you also have to be very aggressive in terms of providing alternatives and providing a better quality of dying process for patients. Now, you mentioned the methods that have been used to prolong life. One of the motivations that has been mentioned for physician aid in dying is an overuse of life-sustaining treatments. That we prolong people in very debilitated conditions to the point that they see suicide as the only way out of this kind of situation. So one suggestion has been made is that we be more prudent in our use of life-sustaining treatments. Palliative care is very, very important. Also, on a personal level, relationships can be very, very important for dying people. Dr. Lonnie Shavelson, who is an emergency room physician, wrote a book chronicling the stories of 5 different patients who had decided to engage in physician aid in dying. And one thing that comes across very, very strongly is a lack of important relationships that these people had. He tells the story of one man who had AIDS. And he had decided to end his own life at a certain point. But before he did that, he wanted to reconnect with the son he had had. And in doing that, he decided against taking his own life, even though his condition progressively deteriorated. He told another story about a man who was essentially jilted by his girlfriend, and after that experience, he decided that his physical conditions were overwhelming.
I think when you talk about relationships, it could go either way. It could also be a very blessed thing, as with Brittany Maynard, that her family was strengthened to come together to be with her. But I see Gary's eyes just rolling, ready to say something over there.
You know, the one thing that that we haven't really talked about yet is that I understand that most of the expenses in the dying process when you're terminally ill are in that last 6 months anyway. And so with this national debate about health care, doesn't this also play into that as well? I mean, do we not pass along the burdens when we die to our family to pick up those costs and to take care of the things we left behind? So isn't, you know, this PAD, this physician-assisted death, also one option to spare your family from expenses and other problems that they may have later on as well?
And I think the question I hear from many people is, how do we know how to answer some of those unknown questions?
Right.
How do we know what we're sparing from? Or are we just doing this to avoid suffering, you know, or to avoid pain? Because we live in a society that teaches us that.
Yeah.
You know, we're very adverse to death and pain and suffering. And we want to go out with dignity and not being shamed and not being totally dependent on others. So I see many, many issues on both pro and con. Becky, you had something?
Well, I was just going to say, from the data in Oregon, we do know that most of the people who went through with death with dignity did have insurance. Many were enrolled in hospice, so they were already choosing less aggressive, less expensive modes of care. They were already choosing palliative treatments. So I think that that's something to consider, that some of the fears that we may have had about people doing it because they didn't want to be a burden or because of the expenses, I mean, I guess you can look at that from either side as well. We don't want people to feel that the only way to save their families from burden and expense is to take their own life. That is not the reason that we want anyone to feel that death should come.
I was talking to a tax lawyer yesterday, and he said, you're not even addressing publicly if you have to change residence, and the taxes involved, and then the insurance is involved, and all that trail of our society's clutter around illness and death. So there's a lot more to this than we even put on the table, than just one person avoiding anything or dying early. Many of the things I've heard is the self-control, pro and con, that we don't have a right to step in when God gives us life, if that's what your faith community believes. On the other hand, self-control and the right to make a decision. The Death with Dignity Center says that's the last gift you can have, is the control over oneself for your family.
Now, in terms of ethical discussions, one principle that is often used in support of physician aid in dying is the principle of autonomy, the right to direct the course of one's own life. However, there has been concern that there is too much emphasis on autonomy. One major theory in medical ethics is called principalism, and that recognizes 4 principles: autonomy, beneficence, non-maleficence, and justice. So autonomy within that schema of ethics does not necessarily trump everything else. Also, if you look at the work that came out of feminist ethics at the end of the 20th century, there's something called the ethics of care, which sees this emphasis on the individual choice as misguided and reminds us we are essentially people who are in relationships with other people. So again, they do not see autonomy as a supreme value.
I understand that, and I wish if I was critically ill or terminally ill and I was going to die, I don't think I would think about all those things. I think I would be thinking totally about what control can I assume when everything around me is totally out of control.
Or even, do I just want it to end? I mean, in fact, actually, that brings up a question. As a doctor, you're not in a state that practices that,
Correct.
but you have the Hippocratic Oath, first do no harm, right? What does that look like then for a doctor that prescribes something that they know is going to cause their death? I mean, I would think that would be an ethical dilemma for doctors.
And that is, and it's a professional integrity issue, and it's why the American Medical Association and others do
is
not
not against
support this. However, I would say that I think when we weigh things like do no harm or non-maleficence and beneficence, or do what's in the best interest of the patient, we're often always thinking that in the best interest is continuing life, prolonging life. And I think that we have to realize at some juncture that that's not always what's in a patient's best interest, and that perhaps doing harm can be prolonging their life. But I would go back to things you said earlier, that there are other ways that we can influence the course of a patient's disease. We can find out their goals earlier on in the course of disease. We can avoid use of technologies and medication that might not be in line with what they want for their future.
And we can't keep everybody alive at all cost in any way. So there's so many issues involved. Our advanced directives even lead us up to this stage, I think, in our culture, because we're controlling how we want to die, but now we've taken the last step with the death to dignity. We have like 2 minutes left. What should we say in conclusion?
Well, actually, I had another question I was curious about too.
Quickly.
The whole concept of the assisted death, excuse me. What if it weren't the state's responsibility to say what drugs you could or couldn't take? Then the doctor wouldn't have to violate their ethics either. If you could take your own drugs in which to end your life, then at that point as well.
Well, you raise good questions, and that calls us to really careful consideration and discussion, and not just letting things go because it's an emotional decision. We've learned a lot today. Do you have a comment, a final comment?
Well, I
Becky?
certainly think we can all agree that adequate pain control, palliative care, helping patients be guided through this time in their life in a way that allows them as much autonomy and decision making as is comfortable for everyone and is legal in the state, can hopefully make these cases very rare. And that's what they're actually finding in Oregon and other states, even where it is legal. And so I think good palliative care and pain management really ought to be at the forefront.
These laws are called death with dignity laws, but I want to raise the question. If someone is reduced to the point that they feel they need to take their own lives and not let the natural disease process take its course, is this really providing people death with dignity? Think, say, of Maury Schwartz, okay, Tuesdays with Maury. He had ALS. He became very, very debilitated. He did not take his own life.
Right. And each case is going to have to be reckoned on a personal basis with the physicians and all the information we have at our fingertips, our faith communities, our doctors, our ethical beliefs, our values. I guess the bottom line goes back to we're all going to die. We don't know how. We don't know when. So maybe today, while we're thinking about this discussion, we can think about our own dying and make our living even better. This has been Ethical Perspectives on the News, and I'm Martha Rogers, and I thank you for joining us this morning. This production has been made possible by the support and services of KCRG and the Interreligious Council of Lynn County. Have a good week and live ethically. Goodbye.